So, good evening,
Student,
all the aspirants. Here we have the speaker, Dr. Varun Pushkarna, Senior Consultant in Internal Medicine at Fortis Scottish Hospital, Amritsar. So, you may take over. Thank you.
thank you, Sana. Good evening, aspirants. We'll be starting the respiratory system for EDIC today. Uh, we'll have some ultra important and then important topics that we will discuss. So, the most important is respiratory failure. So, when do we call respiratory failure? Like we have kidney failure, we have heart failure, same way we have respiratory failure. So, that incorporates failure of the lungs or the whole respiratory system to adapt to the needs of the body. That means oxygen delivery and carbon dioxide elimination. Both of them. Both of them are important. So, whenever there is a problem either with oxygen supply or delivery or removal of carbon dioxide or elimination of carbon dioxide, when the lungs or the system fails to perform its duty, we call it respiratory failure. Now, that respiratory failure, like any, let us say, like any what do you say this for example, for a lazy student, or a poorly performing student, so we see that they are either acutely failing or they are chronically failing. So same way the respiratory system also works as the in the same pattern. Either it can happen acutely when the lungs are absolutely fine with no secondary problem, no underlying disease, no problems at all, suddenly fail to perform their duty. And at the other end of the spectrum are the lungs which are chronically disturbed. They have not been able to provide for the needs of the body on a long term basis. So either the oxygen could never be delivered properly or the carbon dioxide could never be eliminated properly. So they are chronic pulmonary failure or chronic respiratory failure, and these respiratory failures they get acutely disturbed also during the times of pulmonary illness or during the times of increased need of the body. So we will just go through the respiratory failure because it is one of the important critical conditions for which patients are admitted in the ICU, and lot of work has been done on managing the respiratory failure with the intensivists ever since the ICU concept has begun, and it was put to test during COVID times, and we now have much more insight into respiratory failure. So it is a critical condition requiring very, very urgent recognition and fast management. Here are some points that we will discuss today. That respiratory failure is basically the inability of respiratory system to maintain adequate gas exchange. That means the oxygen from air into the blood and carbon dioxide from blood into the air. And whenever we are talking about the air and blood, we are talking of the pulmonary membrane, which is diffusion membrane. That means there are the alveoli, and you are all postgraduate students appearing for an EDIC exam. So I will not go into the diagrammatical details, but you understand that there is an alveoli which is having the air in it or the oxygen admixture in it, which has oxygen, nitrogen, and carbon dioxide and water vapor and extra small amount of other gases also. So, like we talk about the percentages of any gas or anything in whenever they are put together in gaseous admixture, we call it partial pressure. So, whatever is the percentage of that particular gas in uh, uh, that air admixture is known as partial pressure of that gas. So, like partial pressure of oxygen, whatever it will be transported through the pulmonary membrane, that is the alveolar membrane, then through the interstitium of the tissue which supports the alveoli, then entering into the basement membrane of the blood capillaries and then endothelium, and then finally reaching the blood. So this is vice versa, that travel happens for oxygen into the blood and carbon dioxide moves from blood to the empty space of the alveoli. So the type 1 failure, or basically it can lead to two types of failure, which is either low oxygen, or low oxygen may or be not present, but high carbon dioxide level. So type 1 respiratory failure is characterized by hypoxia without hypercapnia. That means the problem is not with the release of the carbon dioxide from blood into the alveoli, but there is a problem for the oxygen to travel from alveoli into the blood. So usually these are the parenchymal diseases like pneumonia, like ARDS, like pulmonary embolism, and like thickening of the basement membrane of the alveoli, for example, IPF, idiopathic pulmonary fibrosis. Then comes type 2 respiratory failure, where not only oxygen is a problem, getting rid of the carbon dioxide is also an issue. So typically happens whenever there is a problem with the expiratory system, that is the bronchioles, that is the bronchi, the trachea. Whenever there are problems, or the whole of the rib cage is an issue, like myasthenia gravis, neuromuscular disorders, so COPD, airway obstruction, and neuromuscular disorders, they are basically the organ systems involved in the pathophysiology of my iPad has turned on, so I will join there as well. So the important thing is the gradients are important. That is, when the oxygen has to travel from air, this alveolar space into the blood, there has to be a gradient because diffusion happens down the gradient. You can throw a ball from ground upwards, but you will have to put a force into it. But from top downwards, you will just have to release the ball and it automatically comes down because there is a gradient of gravity. Same way, when the oxygen is to be moved from alveolar space into the blood, it requires just a gradient. Same way from carbon dioxide to the blood to the alveolar space. So the alveolar arterial gradient, it is the most important measure of movement of the gases between the alveolar to blood space. Then comes the those areas of the airway which do not have any diffusion membrane. For example, the bronchioles, for the bronchi, they are not connected directly in that manner. So they are and they are also being ventilated, although they are the cost that we have to pay for delivering the oxygen to the alveoli. So they are the dead space. So we have to ventilate the dead space also. So that is dead space ventilation. Clinically, the patient, just a second, I am connecting there so that I can teach you better. So clinical presentation could be whenever somebody is having lesser oxygen in their system, obviously they will be dyspneic, they'll be breathless, they'll be gasping for breath, they'll be needing more oxygen. And of course, when oxygen drops, then there is bluishness, discoloration, that is cyanosis. And where do we see the cyanosis? We can see it on the tip of the tongue, on the base of the tongue, and of course on the tips of the fingers and toes. And because the respiratory drive is increased during respiratory failure, tachypnea is there. So, and of course, confusion because of hypoxia and hypercapnia. Now, what point I'm trying to make here is that if you just look at these symptoms, dyspnea, cyanosis, tachypnea, confusion, these are apart from cyanosis, others are very, very subjective symptoms, can be present in many other conditions. May it be oxygen delivery, may it be hemoglobin is low, maybe the demand is increased. All of them can lead to dyspnea, tachypnea, and confusion. And cyanosis can occur in some conditions like admixture of blood. But the worst prognosis in a condition of respiratory failure is there when a patient has all the problems of respiratory failure but is not tachypneic. If the patient of respiratory failure is tachypneic, that is a typical sign of respiratory failure. But if the respiratory failure patient is not tachypneic, it is a sign of impending death, because now they are getting fatigued. Their tachypnea is not, is getting away, and now they are going into shallow breathing and maybe slower breathing, and then they will need intubation. So this is one very important point in the MCQs that you always need to look for, if the patient is respiratory drive is decreased or not. Okay. Then comes the diagnostic tools. Which is the easiest diagnostic tool that you can use in an ICU setup? It is anyone?
The ABG.
The color of the skin. Color of the skin is very important diagnostics to test. So all you need to do is pinch some patient's fingertips and you can see the color in the fingertips. If it is red or dusky red or gray or blue, you can make out the patient is having respiratory issue. This is number one. Then just follow your mind what you will do. So first thing, fingertips. Second, you put a pulse oximeter on it. Easiest test. What is the drawback of pulse oximeter? It depends on the warmth of the hand. If it is too cold, if the perfusion is less, it may not capture. But let us say the fingers are well warm, the pulse oximeter is catching everything fine. But still the pulse oximeter has an inherent problem. Can anybody pinpoint that inherent problem?
Single wavelength.
Say again.
Single wavelength measurement.
It can only show oxygen. It cannot tell you anything about carbon dioxide. That is the inherent drawback of pulse oximetry, that it can only tell you about oxygen. Imagine if pulse oximeter could ever tell you about carbon dioxide, you will not need an ABG for respiratory failure patients. Why? Because saturation you can get from pulse oximeter. Clinically, you can assess the patient. And imagine if you can get carbon dioxide also on the pulse oximeter, then your chapter is of ABG is closed. You will the intent of getting an ABG will be decreased. But that is not the case. The today's, I don't know why the research is not happening to that level that they can tell you about the carbon dioxide saturation of the blood, but oxygen saturation can be told by pulse oximeter. Then, of course, ABG is there to evaluate oxygen and carbon dioxide. Of course, it gives you more information as to what is the pH of the blood, what is the bicarbonate level in the blood, and if there is any methemoglobinemia present in the blood, it can tell you more, and lactates and everything. So, fingertip color, pulse oximetry, arterial blood gases, and yes, chest X-ray and other radiological tests will help you doing the assessment of a patient whom you think is respiratory failure. How do you manage? Simple, oxygen therapy. And that is where the intensivist comes into play. Right from the movement of nasal cannula to intubating the patient, it's all your domain. So can anybody tell me what is the maximum FiO2 that you can give with a nasal cannula?
40%.
Basic question.
40%.
How? How?
We need to count this room air 21%, then we will increase 1 liter 4%, and total
Very
we
good.
give maximum 6 liter.
Wonderful. So basically, for every 1 liter increase in the air, increase in the oxygen that you are giving, you can increase the FiO2 only by 4%. And theoretically speaking, you can go up to 4 liters. Practically speaking, you can go up to 6 liters. So 4 fours are 16. And if you add 16 into 21%, all you get is somewhere close to 37%. And if you go by 6 liters, then theoretically 6 fours at 24, and adding 24 to 21, you can practically go up to 45% of oxygen concentration. You cannot go beyond that. So whatever flows you are increasing on the nasal cannula is not going to add up into the FiO2 levels. Hence, it is very, very absurd to see when the flow meters are boiling up at 10 liters per minute and the patient is on nasal cannula. That is why the demand for high frequency nasal cannula came in. But then we will discuss about it. Of course, oxygen is given to correct hypoxia, but be very careful in patients who have COPD, because their whole life depends on hypoxic drive. If you give them so much of oxygen, you can actually risk them losing their hypoxic drive, and they will become even sicker if you give them higher levels of oxygen. Now, oxygen therapy is different from ventilatory support. Just by giving oxygen, you can give them higher FiO2, you can give them higher chances of saturating their blood with oxygen. But ventilation means inhalation and expiration or exhalation process. If you are helping something in that front, that is called ventilation. And you can give that support by non-invasive techniques like putting a NIV, BiPAP, CPAP, or you can intubate a patient and put the patient on a ventilating machine. If the airways are an issue, you should use bronchodilators. If heart failure coexisting or pulmonary hypertension is an issue, then you can use diuretics. And of course, to reduce the inflammation in the airways and the lungs, steroids are a handy thing, but you have to prove that there is inflammatory disease. Coming to the types of ventilation, non-invasive and invasive. So non-invasive ventilation is when we just put a bag, a mask, a tightly fitting mask on the face of the patient, and we breathe through that, utilizing the natural airway of the patient. So you can use them in COPD exacerbation, acute cardiogenic pulmonary edema. You can use them in some types of hypoxemic respiratory failure. Benefits are that it avoids intubation, it avoids all the complications associated with intubation, it increases patient comfort and reduces the ventilator associated lung injury. Invasive mechanical ventilation is much more effective, is used in severe respiratory failure where you need to control the patient's ventilation altogether, where the patient is unable to tolerate non-invasive ventilation, where the patients are not conscious enough, their GCS is low, they're drowsy, you need to have their airway protection. You need to set a lot of parameters in a intubated patient or an invasive mechanical ventilation. You need to be very sure on how much volume of air or oxygen you want to give. So that's called a tidal volume. That helps the tidal exchange. That is the main ventilation that we are going to achieve. Second is the respiratory rate, through which we try to decide what level of carbon dioxide you want to achieve. Then a positive end expiratory pressure, which is basically the same way, like you don't want anybody to open the door and you are holding the door from inside, you are not letting them open the door, that is the PEEP. Same way, the mask or the intubating in the valve in the ventilator doesn't let the patient breathe out, so the air that is to be breathed out remains inside the alveoli, keeps it patent for some time before it is released into the tubing. So that is called PEEP, or the positive end expiratory pressure. That is, this pressure is exerted at the end of the expiration. It is a positive pressure, just like, for example, somebody was smoking a cigarette and suddenly their mom walks into the room. They just close their mouth and they don't allow the smoke to go out from their nostrils or from mouth, but then it goes back into the lungs. This is what PEEP does. So it doesn't allow the oxygen which was given by the ventilator to go inside the lung. It actually helps it go back and distend the alveoli so that the oxygen can travel from the alveoli into the blood circulation. So all you need to do is put a valve here so that this oxygen, this is PEEP. Monitoring of a patient on ventilator requires a lot of ABGs. Monitor their P-plat has to be less than 30 at all times. Patient's response to ensure appropriate ventilation. There are a lot of complications. We will see that. Now, after we have briefly discussed respiratory failure, now let's look at the questions. A 55-year-old male with a history of COPD is admitted to the ICU with acute respiratory distress. He is a known case of COPD. So we understand this. And he is admitted with respiratory distress. As of now, we are not sure that what kind of respiratory failure this is. We are curious though. So we will get an ABG done. In the ABG, it tells us that the pH is 7.25, PaCO2 is 70, PaO2 is 50. Which of the following is the most appropriate initial intervention? High flow, nasal cannula, non-invasive ventilation, immediate intubation and mechanical ventilation, or intravenous corticosteroids?
B.
B.
The answer is B.
B.
So the answer is that I would like to put the patient on a non-invasive ventilation. Why? What kind of respiratory failure is this? This is hypercapnic or type 2 respiratory
Type 2
failure.
respiratory.
Yes. And
Because
the primary thing,
he has two problems, hypoxia and hypercapnia.
yes, combined, both of them together, and also respiratory acidosis. He has three problems. So we would like to ventilate this patient, but not like to intubate this patient, because this is a known patient of COPD. He will always have a higher carbon dioxide level. Right now, his issue is compounded by the acute exacerbation, which has led to hypoxia and hypercarbia, both of them together. So here we have elevated PaCO2 with acidosis. NIV is the first line. All the guidelines, BTS, everything, everybody says that NIV is the first line treatment to avoid intubation. Number 2, improve ventilation. Number 3, reduce the work of breathing. Very important. So some amount of carbon dioxide is contributed by the accessory muscles of respiration. So when we are putting the patient on NIV, those accessory muscles are put to rest, hence helping the decrease in carbon dioxide levels. Immediate intubation may be considered if the patient becomes drowsy and respiratory acidosis worsens. Okay, then we will need it.
But if can I ask a question? But if we have absolute contraindication for this non-invasive ventilation, like patient is uncooperative, patient have a trauma, facial injury. In this situation, what we will do? We will go for intubation.
Yes. So if
Yes,
you
of
have,
course.
so it is a basically a risk benefit ratio analysis. If your patient is unconscious and has COPD also, then you know that this patient may require extended ventilation for his unconsciousness nature, which we yet have to find out. Maybe it is because of respiratory mismatch. So intubate that patient because he's unconscious. Number 1. Number 2, if the patient has a traumatic brain injury and the patient is in coma because of that, and also the patient has respiratory failure, again the patient needs intubation. You will not put this patient on NIV because the risk of aspiration is very high. You need to control the airway also. So wherever there are chances that the patient can have further compromise because of unable to maintain their airway, then the benefit should be taken from intubating the patient, not giving them risk of not intubating. For example, if the patient has arrested in front of you, but you know that the patient has respiratory failure also, chronic respiratory failure, COPD, you will still intubate the patient. Why? Because the need of the hour is to intubate. Second is hemodynamic instability. For example, if the patient has a BP of 70/50 and with the same blood gas, I will not put the patient on NIV. I will intubate the patient because this acidosis is causing cardiovascular compromise. Again, if the patient has hypoxia so much so that the patient has developed a seizure, patient has thrown a fit, then again you will intubate such a patient. So whenever you have a contraindication, you should see if that contraindication will be benefited by intubating, then definitely go for intubation. Then the answer will change.
Thank you.
Second
Thank you,
question
sir.
is, no problem. Second question is, a 32-year-old female with a history of asthma is admitted to your ICU with severe shortness of breath. Her peak expiratory flow is 30% of the predicted value. Which of the following treatments should be initiated immediately?
B.
B.
So, high dose steroids, nebulized long acting bronchodilator, intravenous magnesium sulfate, or Heliox? So, the answer is
B.
B.
B. That is nebulized salbutamol. So, this patient has severe asthma exacerbation, and all you need is bronchodilation. So, you need this patient to be nebulized continuously with salbutamol. Steroids are important, but the problem with steroids is they will need some time to act.
Onset
So,
action is very
yes,
slow.
onset of action is slightly, later. They will get converted to their active components and then they will start showing their effect. So, you need immediate action. So, all you need is a bronchodilator. Dilate the bronchi, let the asthma attack wean off, and if still the problems persist, then we can take our regular calls. A 70-year-old male with pneumonia. Now we have moved from simple type 2 respiratory failure to bronchial asthma. Now we are having respiratory failure secondary to pneumonia. So a 70-year-old male with pneumonia develops ARDS and is intubated. This patient's chest X-ray shows bilateral infiltrates. Which of the following ventilatory strategies is most appropriate in this patient? So
B.
basically,
B.
B. So that is 6 to 8 liters of 6 to 8 ml per kg of tidal volume. We all know that in ARDS, we will discuss more about it later. Low tidal volume ventilation is recommended. Why? Number one, the baby lung concept, that the lung that is surviving is the lung which is contributing to oxygen. The lung which is damaged is the lung which is not contributing. So we are not ventilating that lung which is not contributing, we are ventilating that lung which is still healthy. So if the 30% of the lung is only left, we will not ventilate with 100% of the lung volume. We will just decrease the amount, that is 6 to 8 ml of per kg body weight, and we will ventilate it with lesser volume so that we avoid over distension of the healthy lung. We avoid volume trauma to the healthy lung, whatever is surviving. We avoid barotrauma also to the healthy lung. So we will use lesser tidal volume. We can use high PEEP available from the ARDS net chart, and we should be very, very careful in avoiding any type of ventilator associated trauma to the lungs. Next question, a 45-year-old female with a history of SLE presents with acute onset dyspnea and hypoxia. Chest X-ray shows bilateral interstitial infiltrates. What is the most likely diagnosis?
C. Acute interstitial pneumonia.
C.
So, acute interstitial pneumonia is one of the leading pulmonary complications of SLE. However, there are other diseases also like renopulmonary conditions like Wegener's granulomatosis, EGPA, CGPA. So, if they are the conditions involved, then they can even lead to rupture of the pulmonary membrane and cause hemopsis. So in those conditions, it is a different pathology, but here acute interstitial pneumonia is usually the norm in SLE, and because it happens over a span of like few days, steroids and nebulized steroids, both of them, they are helpful. In fact, if the patient is a known case of SLE, then you will need to give a pulse therapy of methylprednisolone. Okay. So next question is, a 60-year-old male with a history of smoking presents with sudden onset dyspnea, chest pain, hypoxia. D-dimer level is elevated. Which of the following is most important next step?
CT should be.
So very important. Now here is a full algorithm here. You need to triage this patient. The kind of situation they have told you is a patient who has come to you in probably an OPD or emergency room, but the patient is stable enough to get a D-dimer level done. So that means this patient can be taken up for a CT pulmonary angiogram. Otherwise, for example, if this patient comes to the emergency room and the patient is so sick that CT pulmonary angiogram cannot be done, then what will you do?
Echo.
Yes, then we will like to do an echo. So on echocardiography, you will be able to see an acutely dilated
Right ventricle.
RA and RV, okay, with in TR, tricuspid regurgitation, and pulmonary arteries, this PA
Hypertension.
systolic pressures almost matching the blood pressure, systemic pressure. If this patient turns out to have pulmonary embolism with CT pulmonary angiography, if the patient is stable, then you need to start anticoagulants to the patient.
Hyperintention only.
Yes. But if the patient is unstable,
TPA.
then you need to give. And if the patient has had a cardiac arrest, then
CPR.
of course CPR plus
TPA.
CPR plus TPA. So in that situation, you will still give them TPA as a last resort, because sometimes when you give TPA, the CPR will become effective. If you do not give TPA, no matter how much CPR you do, if there is a saddle thrombus in the pulmonary artery, nothing is going to come out of it.
Because
so
obstruction.
Yeah. This is pulmonary embolism. All right. A 50-year-old male with history of alcohol use presents with fever, cough, pleuritic chest pain. His chest X-ray shows a large pleural effusion. Which of the following is the immediate next step? What will you do here? What is the diagnosis here?
Large pleural effusion. So it's thoracocentesis.
Yes. So the diagnosis here is most likely empyema, thoracis. So you need to drain it plus give antibiotics. Okay.
So what was the answer of the last question? Next was echocardiography or CTPA, sir?
CT pulmonary angiogram.
Okay. Okay.
Yeah. So here the patient has a X-ray. So there is a large pleural effusion. So the next step is to take this fluid out for echo synthesis. Can anybody tell me what kind of pneumonia these patients who are having history of alcohol do they have? What kind of pneumonia do they have? So they have a typical cavitatory pneumonia known as Friedlander's pneumonia. Very important from intensivist's point of view. These patients, they have large cavities. And why is it important for us? Because of a special kind of problem, that is necrotizing pneumonia.
Sir, here this scenario,
Yes.
we cannot go for the CT scan of chest, as you mentioned. This patient have a cavitary pneumonia. So how cavitary pneumonia, you cannot go through direct thoracocentesis, because this will be a different area, pleural fluid will be there. Right? So we cannot go for the CT scan chest first and to rule out the proper location of this empyema and fluid, and then go for thoracic.
Yeah, with the amount of information provided, you can safely go for thoracocentesis. I was only telling you about the cavitary nature of this pneumonia because it will be, it is one of the differentials. You are right. So it is one of the differentials that you need to know, that the alcoholic patients can have this. So if the patient has, in the question stem, if it is given that patient has a large pleural effusion, now the working diagnosis is empyema. The best treatment is to put a thoracocentesis. Of course, now you will have better options in the exams like ultrasound guided thoracocentesis. You getting my point? So if you are doing ultrasound guided thoracocentesis, and if it is a large pleural effusion, no matter where you put the needle, it will not enter into the lung anyways.
Okay, I'm coming.
Yes? A large pleural effusion, you will need a very long needle to puncture the lung. It is the norm is to put the needle there in the thorax and take out the fluid. If it is pus, you need to drain it with a chest tube.
Sir, sorry.
Yes, but I do get your question that if this patient has Friedlander's pneumonia or it a cavitary pneumonia, then should we not go in for a CT scan? We can as a protocol of the organization, but if you go by the protocol of the guidelines and the recommending organizations, there is no such direct protocol that if you have a patient who has presumed empyema that you need to get a CT done. The first and foremost thing is to put in a needle and most likely ultrasound guided aspiration to get a sample and culture and maybe relief also.
Yeah.
Okay.
Yes.
I was just curious. So, most appropriate next step. So, actually, in the sepsis, we go for the antibiotic first. Not like this, sir.
So, the
Antibiotics.
antibiotics, of course, antibiotics you will like to give, but not, I mean, you nevertheless will give. But the most appropriate step is to take a culture first.
Sure, sir.
So, if you need to take a culture, you need to take the tissue sample first. So, you put in a needle, take out the pus, send it for culture and give empirical antibiotic then.
Okay.
If you've given the antibiotic first and then taken out the sample, I think you will be, theoretically you will be wrong, although practically we all do this thing. We give both of them together, put in a needle and put in an antibiotic together.
Yes.
So,
thank you, sir.
Theoretically, for exam purpose, you need to take the sample out first, antibiotic later.
Thank you, sir.
So, thoracocentesis is essential to analyze the pleural fluid, which can help diagnose the cause of effusion also. Okay. And many times, for example, in SLE and all, no, sometimes the patient will have fever. It is only that the data says that the patient is alcoholic that we got carried away that this is empyema. If an alcoholic patient can also have SLE or rheumatoid arthritis or even tuberculosis. See, even if it is tuberculosis, then giving antibiotics earlier on may not help. You need to take the sample out. So, as per the guidelines and recommendations, we have to walk. And in this case, we definitely need to take the fluid out first and then take any other call. Okay?
Okay.
A 65-year-old female with a history of hypertension and diabetes presents with acute onset dyspnea and hypoxemia. Her chest X-ray shows bilateral pulmonary edema Which of the following is most likely cause? Now
B.
this
B.
patient has hypertension and diabetes and is 65 years old. So she has actually presented what I feel with heart failure. And all agree with me?
Yes.
So this patient has risk factors for landing up into heart failure
Hmm.
and bilateral pulmonary edema. I mean, pulmonary edema has to be bilateral only. So X-ray shows bilateral shadows, bat wing appearance. That is what they basically intend to know. So this is acute cardiogenic pulmonary edema. And when we say acute cardiogenic pulmonary edema, it is not ARDS. ARDS is particularly defined as non-cardiogenic pulmonary edema. So the answer will become second, B.
B.
So it is cardiogenic pulmonary edema. Next is, now as we progress, the questions will become more and more technical. A 45-year-old male with history of chronic obstructive pulmonary disease is intubated and is ventilated. He's just 45. His ABG shows 7.30 pH, carbon dioxide of 60, oxygen of 70. Which of the following ventilatory strategies is most appropriate, or ventilatory settings? That is tidal volume of 10 mils per kg, tidal volume of 6 mils per kg, PEEP of 10 or PEEP of 20. So what is the diagnosis? It is a respiratory failure type 2. There is hypoxia and there is hypercarbia. There is respiratory acidosis. Patient is on ventilator. What will you like to do?
The answer is
P.
B.
P.
B.
P.
So we would just try to have lung protective ventilation.
P.
This is what I wanted to hear from you, that we need to do lung protective ventilation. And lung protective ventilation has 4 to 5 parameters we will discuss. But right now, the most important parameter is right in front of your eyes. That is number B. We've already discussed. So the question can change their format, but the answer will remain almost the same. That is tidal volume of 6 ml per kg. So this patient has ARDS plus. The problem is that I don't want to give barotrauma to this patient because this patient has COPD. So they can develop pneumothorax, pneumomediastinum secondary to barotrauma. We don't want that. So high PEEP is not required because the PEEP, what is the target PaO2 in patients of ventilated on ARDS?
60 to 80.
Yeah, so the patient fairly falls in that level, right? PaO2 is 70. So we don't want any extra PEEP in this patient. Whatever PEEP is being given is absolutely fine. A 30-year-old young female with history of asthma, this is the repetition, severe dyspnea and wheezing, the peak expiratory flow rate is 50% of predicted value. What would be the treatment? This is again nebulized salbutamol. So just need bronchodilation. Okay. A 70-year-old male with history of smoking presents with acute onset dyspnea, cough, fever. Chest X-ray shows multifocal infiltrates. Which of the following is the most appropriate initial treatment? Very easy question. You've been saying it. Now it is in front of you.
D.
So we would like to give this patient empirical antibiotics.
Yes.
We are all familiar with the curve 65 scoring. Yes. What is C?
Curves.
So curve 65 score is basically intended to be used in patients who have suspected pneumonia. Which pneumonia? Community acquired pneumonia. So we call it CAP, community acquired pneumonia. So C is confusion or cerebral obtundation. U is urea more or uremia. R is respiratory rate more than 30. B is BP less than 90 systolic, and 65 is age more than 65. So this tells us about how will you manage a patient of community acquired pneumonia. Will you manage the patient if the score is less than 2? You will manage this patient in OPD. If it is anything more than 2, you will manage it in the hospital. If it is more than 3, you will manage the patient in an ICU. So this at least 70 years gives you a fair amount of idea that 1 out of 5 is there. Okay. So it is very, very important that you start antibiotics in this patient, presuming this patient to have pneumonia, because just by his age, he has already 1 point in the curve 65 scoring. Is that okay? So the clinical presentation suggests pneumonia and empirical antibiotics should be given immediately. A 55-year-old male with history of COPD is presented to your ICU with acute respiratory distress. His arterial blood gas shows pH of 7.25, CO2 of 70 and PaO2 of 50. This is again a repetition. So what will you do?
B.
Okay. So this is B. Let's understand the ARDS. So ARDS is one of the most severe form of lung injury that we have ever encountered in clinical practice. It is characterized by widespread inflammation and fluid accumulation in the alveoli. So what happens is that like a joint gets inflamed after injury or because of arthritis, these alveoli, they suddenly get filled with blood. Oh, water. So there is fluid leading to, now there is oxygen. Problem with the oxygen is that it is not water soluble like carbon dioxide is. So this travels into the blood with difficulty. However, carbon dioxide, as I told you, it is water soluble. It can still go through the alveoli. So the patient has hypoxemia and this is ARDS. You need to give them enough pressure for this oxygen to travel through this fluid into the blood. So there is impaired gas exchange and it is a rapidly progressive syndrome, will lead to hypoxia and respiratory failure very fast. Important is that it should be not because of left heart failure or any fluid overload. Earlier, the definition was Berlin definition, where we realized that ARDS was expected whenever a patient who presented with symptoms since 1 week with worsening symptoms. Chest imaging shows bilateral opacities not fully explained by effusions, lobar, lung collapse, or nodules. Origin of edema was specifically not due to cardiac failure or fluid overload. And oxygenation was basically the hallmark of diagnostic classification, whether it was a mild, moderate, or severe. Whenever the PaO2 or PF ratios were less than 2, it was called mild, less than 100, it was moderate, and severe was less than 100. Basically, my regular funda to tell my students is that the lungs, they are kind of a step up transformers. So if in room air the oxygen is 21%, then we understand that the PO2 is 105 millimeters, which is 5 times. So normally the lungs will convert the figure of 21 to 105, which is 5 times. So if the patient is not able to maintain even equal to whatever you are giving 100% oxygen and their PO2 is not even 100. that is the time when the patient begins to start getting sick. That is the PF ratios of less than 1. But even if it is just doing twice as much, for example, you are giving 21% oxygen and they are maintaining only 42 mm of PaO2, even then it is mild ARDS. But with the changing guidelines, we do have now latest new global definition of 2023 where they have introduced some changes. So time to installation is up to 7 days, same, no change. Pulmonary edema not explained by cardiogenic, no change. Radiological feature, earlier it was only bilateral infiltrates on chest X-ray or CT. Now, lung ultrasound also has been labeled as a one of the diagnostic features of ARDS. Then the hypoxemia definition, in that HFNO has been added, that if a patient is not able to maintain a PF ratio of 201 to 300 with NIV CPAP or PEEP of more than 5 or HFNO more than 30 liters per minute, then we have mild ARDS. This is the first time when HFNO was introduced in the definition of ARDS. And now saturation versus FiO2 ratio has also been introduced, which was not there earlier on. So earlier we used to have only PF ratios. Now we have SF ratios also. So if the saturation is less than 97 and the PaO2 is less than 315 on 100% oxygen, then we can say that the patient has ARDS. So the key clues are acute onset bilateral opacities, PF ratios of anything less than 300, and provided the patient does not have a cardiac failure. We all understand that there is basically a problem with the alveolar capillary barrier which gets disrupted. Injury to the membrane leads to increased permeability. The fluid enters into the alveoli, flooding the whole space. The inflammation is the one that starts everything, and hypoxia is what is the end result of it. Sometimes direct injury happens like pneumonia, aspiration, inhalational injury, or acute pulmonary edema. But sometimes indirect lung injury like pancreatitis, like sepsis, trauma somewhere else, major surgery, they can also lead to ARDS. Presentation typically is dyspnea that worsens over hours to days. Hypoxia could be mild to severe. Chest X-ray can show have to show bilateral infiltrates, and now the ultrasound imaging is also included. The point of note is that it should not be a cardiogenic situation. Usually, the supportive care begins with the escalating oxygen therapy, going from nasal cannula to intubation, ECMO, and everything, and trying to treat the underlying disease. Ventilatory support pitches in whenever we are unable to maintain the oxygenation or ventilation or respiratory failure with non-invasive ventilation or by HFNO. Even if you have to ventilate such a patient that you usually do, you will need to use low tidal volumes, and PEEP has to be given to recruit, that is to keep the alveoli open to improve the oxygenation. Fluid management has to be conservative. What is conservative fluid management? Anyone? Anyone?
Means not,
So,
we will avoid overfluid this
yes.
patient.
So if
Just
you have
we
a
will
very strict
keep patient to U volumic.
U volemic, so intake output balance should be strictly 0. So because it is a ventilated patient, insensible losses can occur only because of fever. Otherwise, HME filter and everything will not let the insensible losses. So theoretically, what I have calculated and keep telling my residents, which doesn't work as far as the guidelines are concerned, it is 1 to 2 ml per kg body weight fluid you can give. If the patient is in prone ventilation, you are not even able to give them feed. So hydration becomes all the more important there, but you do make it a point that you don't overhydrate these patients. Treating sepsis or anything which is contributing to ARDS is paramount. You need to do that. Source control is important. And nutritionally, early enteral feed is recommended if the patient is in propped up position. In prone position also, you can start, and if the patient is tolerating it, continue with the enteral feeding. Do not miss on enteral feed. EDIC exam keeps asking in true and false that feeding. So feeding is very important. It is equally as is DVT prophylaxis. So these patients you should always give them DVT prophylaxis, because of these patients in which we are using high PEEP, the venous stasis is more, and the chances of DVT are also more. So ventricular arrhythmia, barotrauma, pulmonary hypertension, infection, DVT, all are the one of the complications. So a 70-year-old male with pneumonia develops ARDS, is intubated, X-ray shows bilateral infiltrates. Which of the following ventilation strategies is appropriate? It is 6 to 8 ml per kg. Low tidal volume, it is kind of a repetition. A 45-year-old female with history of SLE presents with dyspnea. This is acute interstitial pneumonia. And now we come to pulmonary embolism. So pulmonary embolism, very serious condition, occurs when a thrombus moves from, usually from the legs, DVT, or even superficial, these upper limb DVT has got higher incidence of causing pulmonary embolism. It travels to pulmonary arteries. So embolism is when the artery gets blocked, and this is the pulmonary trunk. Sometimes the saddle thrombus blocks everything. So the thrombus usually is formed in the legs and then it goes there. So basically pulmonary embolism is movement of a clot from some other place to the destination, and the destination is always named first. So it is pulmonary embolism when the clot moves from legs to the lungs. And you should keep in mind about the risk factors like prolonged immobility, surgery, trauma, cancers, obesity, history of smoking, hormonal therapy, travel history more than 6 to 8 hours, genetic predisposition, presence or absence of SLE and other autoimmune conditions. Whenever you have a question where a DVT might be suspected, you should look for any features mentioned like swelling or pain or redness in the affected leg or affected arm. The history should be acute. It should be sudden onset dyspnea to call it pulmonary embolism, acute pulmonary embolism. Otherwise, there is a condition known as CTEPH. Anybody? What is CTEPH? So, it is chronic thromboembolism related pulmonary hypertension. So, pulmonary hypertension nowadays is divided into many classes. One of the class type 3 is thromboembolism related, which is chronic thromboembolism related. So that is something else, but the patient is dyspneic there also, nevertheless. But here the presentation is acute. Chest pain may be present because of the infarction of the lung. It may be pleuritic. Usually these patients have tachycardia. So that is the first sign of presentation, first sign where you can detect a patient has developed a pulmonary embolism. Then, of course, hypoxia, low levels of oxygen in the blood, cyanosis, blue discoloration, all of them may be present. Diagnostic tools are number 1, D-dimer, number 2, CTPA, number 3, VQ scan, number 4, ultrasound used to detect the DVT. CTPA is the gold standard, but if you cannot do, then definitely echocardiogram is a very handy device. Sometimes, luckily, if you can see a thrombus dangling in the pulmonary artery or in the right ventricle. You can see it, and then that becomes a cause and effect relationship. Otherwise, echocardiography will show you dilated right ventricle, presence of a significant tricuspid regurgitation, and elevated pulmonary artery systolic pressures. How do you manage? Mainstay is anticoagulation and thrombolysis. Embolectomy is done in severe cases and sometimes to prevent. Nowadays, although it is not indicated in many situations, the IVC filter is an important one to prevent against DVT. But IVC filter itself is a problem. Hence, it is not recommended nowadays. Only where thrombolysis or anticoagulation long term is contraindicated. For example, a patient who has recently had a subarachnoid hemorrhage and is lying in your neuro ICU and has a DVT, what are you going to do? You are going to ask for a cardiologist to put in an IVC filter. Otherwise, you cannot give anticoagulation. Thrombolysis is out of question. The patient has had a recent subarachnoid hemorrhage and you cannot do anything for that. But you don't want to lose the patient to a pulmonary embolism as well. So complications would be definitely death is a very, very important complication. If you do not treat and act fast, the patient can die with a massive pulmonary embolism. There are three types of pulmonary embolism: massive, submassive, and mild, moderate pulmonary embolism. So massive and submassive are the categories where you need to thrombolize these patients. And the agent to thrombolize, I have made one pagers for you also that I'll give you and share with you, and you can download them for your uh, preparation. Now, next question: a
Hello.
50-year-old.
Hello.
Yes.
So one thing, big questions the you ask about the diagnosis of pulmonary embolism. We can go ultrasound, CT, this one. So the ECG it's not include new guideline.
ECG is, it is the prevalence of ECG findings is just 30%. Okay. So,
Okay.
and specifically S1, Q3, T3 pattern is restricted to even less than 30%. So, if you are going by the diagnostic uh, ECG, then ECG has no place. It can add to the diagnosis. It can help you and suggest. ऐसे तो patient can have a right bundle branch block pattern. The right axis deviation can be there. So acute onset RBBB will be there. We can all say that. But then it is all a corroborative finding. It is not something that you can say, oh, this patient has RBBB, thrombolize this patient. Diagnostic test is where the treatment becomes defined. Not that you
Okay.
will need something else too.
And IVC filter you just mentioned about. We can not go for like discuss more indication, like some patient not compliance with anticoagulation medication, some patient have a recurrent this one DVT problem like micro emboli, and this
So,
two.
yeah, the AHA and ESC, European Society of Cardiology, and AHA, they are very clear on it that all you need to do is anticoagulate these patients with NOACs. Now, if somebody has had a DVT and pulmonary embolism, and if the patient is non-compliant, then you know that if the patient is on IVC filter, the problem of having a thrombosis of the IVC filter and then consequent lower half of the body becomes edematous and perfusion problems happen. You will not put an IVC filter to even a patient who is not compliant with the medications. I know at least 2 or 3 patients who had been put on IVC filter for DVT some 10 years back, and now these patients are on warfarin because the IVC filter has got clogged. You getting my point?
Yes, sir.
So it is such a problem to have an IVC filter that you will require it to be removed after few years. And if the patient is non-compliant, there are chances that they will not get it removed also. Then it will get clogged. And when it
Okay.
gets clogged, then it will be a problem. It itself will become a source of embolism.
Thank you, sir. Thank you.
So usually permanent filters are not put. So these are usually retrievable filters that we prefer, taking them. But then as the age grows and the problems increase and patients become hypertensive, then these filters, they can get embolized also. They themselves get embolized into the lungs. That's one of the biggest problem. Then the filter fracture can happen, and filters can perforate through the IVC wall and causing a catastrophic peri IVC hematoma formation. So the guidelines were published, I guess, in 2021 by all of them. These American Chest Physician Society, the chest guidelines, and then AHA, and everybody told and everybody said that IVC filters must not be put routinely who can receive anticoagulation. And now you have much safer anticoagulants. The NOACs are excellent drugs. Excellent drugs. Okay. So can we move forward?
Okay.
Yes.
Sure.
A 30-year male with a history of alcohol use. I don't know what is happening. Some questions are getting repeated. I only made this class. A 40-year-old male with severe asthma exacerbation is in respiratory distress. He's unable to speak in full sentences and has a respiratory rate of 30 per minute. What is the most appropriate initial airway management intervention? So what will you do? This patient has respiratory distress and the respiratory rate is 30 beats per minute. He is 40 years old and asthma exacerbation is there. What will you do?
The answer is D, oxygen through nasal cannula.
So oxygen
The
via
NIV.
nasal
See.
cannula or high flow nasal cannula. So in asthma exacerbation now, high flow nasal cannula is a very important modality that you can use in patients of asthma exacerbation. Specifically, it avoids using NIV, avoids intubation, and oxygen by nasal cannula will not be enough. So HFNC will take away the work of breathing also. So HFNC can provide significant respiratory support and improve oxygenation and avoid intubation in patients of asthma. Now, if we have to compare the HFNC with what are the usual indications of HFNC, anyone? So the number
Type 1
one
respiratory failure.
type 1 respiratory failure. So that is the first indication, respiratory failure type 1. So for example, COVID pneumonia, for example, community acquired pneumonia, for example, ILD exacerbations, for example, pulmonary edema where CPAP cannot be tolerated, for example, asthma exacerbations. Okay. And so these are very important indications. Otherwise, other are the extubation and pre-intubation kind of situation, or where you do not want to intubate, or DND is there, like do not resuscitate, and all those orders are there. Otherwise, it is an excellent device, this HFNC. Now, what are the how does it work? It basically gives very high flow rates. Now, these flow rates are in excess of uh,
50 liters per minute.
60, 70 liters per minute. So now when you are giving at such a high flow rate, what do you generate? You don't allow the patient to breathe out. Okay. So the flow is so much, 60 liters per minute. If some air is blowing on somebody's face, how are they going to blow out? So it gives some sort
Pressure.
of peep, some sort of peep also. So some sort of peep is added, like around 5 centimeters of peep is given. And you can use a precise FiO2 control also. So these are some advantages. So that you can, with the HFNC, you can give like 100% oxygen or maybe 99% oxygen just by altering the flow. You can humidify. Now the problem is that in NIV, non-invasive ventilation, humidification is a tough thing. Unless you have a humidifier attached to it. And so HFNC is slightly better than NIV in cases of respiratory diseases. In cases of cardiac conditions, NIV is superior to HFNC at all points. We cannot use them in hemodynamic instability when the GCS is also poor. Why? Because if the flow rates are so high, some amount of that air will also enter into the stomach, causing gurgling, and that can lead to aspiration. So but even with that HFNC, you need to have an awake patient. If the patient is unconscious, you should either intubate the patient or try to find the cause and treat the unconsciousness before putting the patient on HFNC. Okay. So HFNC now is being utilized. Not all the HFNC devices which were purchased by the hospitals are kept in the storeroom now. So they are being actively used in the management of type 1 respiratory failure, although the therapy I feel is little more expensive than putting the patient on NIV.
The maximum how much this COPD patient we can give this HNFC flow?
You can go up to, see, in COPD patient, the problem is hypoxic drive also along with. So that is
Yes.
why COPD was not mentioned. It is usually type 1 respiratory failure. It is bronchial asthma patient. Now, bronchial asthma patient is not a typical COPD patient. So in COPD patient, if you are using, because this patient has tachypnea, sometimes they're terminal COPD patient, they are emaciated, they do not have a muscle mass, so they are tachypnic, and you decide, okay, he's not getting a mask which fits him well, so let's try HFNC. Do not go above 40% FiO2 in these patients.
40%.
Yeah.
But the flow rate can be increased as much as possible. Yeah.
Yes, and flow rates will actually help in the ventilatory exchange also.
Yeah.
It is just like taking a metro train at New Delhi metro station. All you need to do is stand there. There's so much of public, they will push you into train and pull you out of the train by themselves. This is what happens in HFNC also.
No,
So
the
they will
flow.
bring the
I have question here. The flow rate, 15 liter, 16 liter, we can go. This from machine we can like fix 40%, and we are using this HNFC.
yes.
But how much patient will get? How much he will get oxygen through this HNFC?
See, whatever
No,
you are giving through HFNC, the entrainment usually does not happen. Entrainment you are giving with the flow only. So here the FiO2 what you have fixed, the patient will get. The problem is with other devices where entrainment happens with the air. So when you
Okay.
are giving them, let us say 10 liters or 4 liters of oxygen through the O2 mask, you don't know how much air the patient will pull in from the atmosphere. So we don't have a absolute percentage in those cases. Here, the flow is so wild that all the flow that is coming to entrain or decrease the FiO2 will come through the HFNC only, because there is no way that a man can pull in 60 liters in a minute from air without getting exhausted. So whatever entrainment occurs and whatever dilution of FiO2 occurs will be diluted there, and only then the percentage is fixed. So if you say 40% oxygen with 60 liters of airflow, then automatically the software adjusts to give 40% oxygen. Otherwise, the patient will become hypoxic.
Yes, usually is the flow rate from the wall that is used to adjust the FiO2.
Yes.
Yeah, but the machine itself now generates the air that the blender uses to combine them to give the FiO2.
Absolute FiO2 that you need.
Yeah.
Correct. Yeah. So is that okay? Next, can we move?
Yes, sir.
A 65-year-old female with COPD with acute hypercapnic respiratory failure is being considered for NIV. Which of the following is a contraindication for NIV? Conscious and cooperative patient is a prerequisite. Hypoxia with PO2 of less than 60, of course. We put patients.
D.
Use of accessory muscles
D.
is an indication for NIV, not a contraindication.
B,
If somebody,
B for acidosis.
I think the answer is B, acidosis. When the pH is less than 7.25. Because if the patient is not using their accessory muscles, why would you put that patient on a NIV support?
Okay, sorry.
That is one of the indications to put the patient on NIV. So the answer is having an acidosis. Severe acidosis with pH of less than 7.25 is a contraindication to NIV, as it indicates severe hypercapnia or metabolic acidosis, requiring invasive ventilation. A 30-year-old male with head injury is intubated in ICU. The cuff pressure is checked and is found to be 40 centimeters of water. What is the appropriate action that you need to take?
D.
B. Decrease cough to 25 to 30.
Yes. So
D.
you need to remember that 25 to 30 is safety. So it is very important that this is where you need to keep the pressures, 25 to 30 centimeter. Recommended cuff pressure, I have a full slide on cuff pressures, don't worry. Because these are the questions that everybody misses and then they get stuck in the exam. Recommended airway cuff pressure for endotracheal tube is 25 to 30 centimeters of water to prevent tracheal injury while ensuring an adequate seal. So what is the endotracheal tube cuff pressure? Key concepts that you need to remember is 20 to 30. Good is 15 to 22. Why maintain this optimal cuff pressure? Because if it is too low, it will allow for micro aspiration. This is the endotracheal tube and this is the cuff. Let us say if it is loose, the secretions will trickle down from side. So micro aspiration will happen and VAP will occur. This is one of the proposed, and actually this is the mechanism for ventilator associated pneumonia or tracheitis. Inadequate airway seal will also lead to leak of the air outside and loss of PEEP will happen and ineffective ventilation can happen. If it is too tight, if it is too tight, it will tamponade the blood supply of the trachea, causing tracheal necrosis. So tracheal mucosal ischemia happens, risk of stenosis, necrosis, ulceration, fistula formation, maybe tracheocutaneous, tracheoesophageal, all of them can happen. How do you monitor? You monitor with it, a cuff manometer is there, which is either manual or digital. You need to check it how many hours? 8 to 12 hours and more frequently in high risk patients. In one of the EDIC exams, even the checking duration was kept in the true and false question. So as small as this, 8 to 12 hours it need to be checked. Adjust with minimal occlusive volume technique if manometer is unavailable. So what are the clinical pulse? Nitrous oxide diffusion into the cuff may increase pressure. So if the patient is in operation room, operation theater, make sure that the pressures need to be checked more frequently if you are doing long time surgeries, because nitrous oxide can diffuse into the cuff and can increase the pressure. So you will need to repeatedly pull out some volume of air or nitrous, whatever it is, from the cuff deflation. So you have to do cuff deflation. In ICU settings, cuff pressure monitoring can be done continuously, which will be, you will see that it will be recommended in the guidelines also. So use of subglottic suction devices can help reduce VAP risk. Why? Because if there is microaspiration, you need a subglottic suction device. Mnemonic is 20-30 for safety. Helps remember safe cuff pressure in the range of water to prevent aspiration and protect the mucosa. Okay. A 55-year-old male with ARDS is on mechanical ventilation. The current PEEP level is 5, FiO2 is 60%, and the patient's PaO2 is 70. What is the next step in managing this patient? Yes. What will
Increase PEEP.
Yeah. So the only answer that we have here is increase the PEEP to 15 from 5 for managing this patient's ventilation. That is the only answer that we can give. Why? Because decreasing PEEP to 0 is not the option. Increasing FiO2 to 1 is not the option. Performing a recruitment maneuver will be required if the PaO2 is less than 50. Here the PaO2 is 70. It is well in the good range. Because it is a question that has been framed, so you will need to make an answer. So the safest answer is A, that is PEEP to 50. So
maximum how much PEEP we can go to ARDS patient?
So there is no maximum or minimum, there is optimum. You have to understand that you can go up to 20 peep, 20, 22 peep. Now, if somebody can tolerate, their lungs can tolerate, you can keep on adding the peep. But the thing is that there will come a deflection point where the moment you increase the peep, the saturation will go down. Or the oxygenation will burst.
It's also best if it's possible to measure the to insert an esophageal balloon to measure the esophageal pressure. Then you can use that to actually determine the transpulmonary pressure, and so with that you can set the optimum PEEP, by determining the transpulmonary pressure.
It can help you measuring the venous return and esophageal intrathoracic pressure. It can help you monitor, and you can find. But again, the point that is to be made is that the sole reason for PEEP is oxygenation.
Yeah.
So whatever you do, you have to ensure that it helps the oxygenation, and second is that it does not cause any untoward events like hypertension, like
Barotrauma.
barotrauma, and so on and so forth, PEEP dependence, and the lung becomes so flail that it becomes useless later on. So the PEEP has to be targeted with the help of the ARDS net chart. This is by the guidelines. You have to follow that. So as far as the PEEP and ARDS are concerned, the best is to follow the ARDS net guidelines. So PEEP is the pressure, we understand, that is maintained in the lungs at the end of the expiration during ventilation. It prevents the alveolar collapse. It improves the oxygenation by recruiting the collapsed alveoli. So we are using a knife to cut the cake. This is so important to understand that it is a detrimental thing, but we are using it to our advantage. We have to make sure that it only remains useful to our advantage only. So physiological effects and therapeutic benefits of PEEP are that it increases the FRC, it decreases the intrapulmonary shunt, it increases the oxygenation, and it prevents. Just a second. ले जाओ तो बोले दोबारा से OTP generate कर. Yeah. So the PEEP helps by increasing FRC, by decreasing the intrapulmonary shunt, by increasing oxygenation and preventing the villi, that is ventilator-induced lung injury. So recommended PEEP settings in ARDS net, just for you, it is like 0.3, you can keep 5 to 8, and the moment you go up to 100% FiO2, you can theoretically go up to 14 to 18 plus PEEP. Complications are decreased cardiac output due to decreased venous return, and barotrauma is the lung injury that happens, along with over-distension, volutrauma, and increased ICP is also there. How to optimize? Use the PEEP FiO2 tables from ARDS net. Use recruitment maneuvers, which is a brief high-pressure ventilation, provided that you decrease the driving pressure less than 15 centimeters at all times. Now, you need to remember that low tidal volume is needed. 6 ml per kg body weight is the key in ARDS. Keeping PEEP plateau less than 30 at all times. Using higher PEEP in moderate to severe ARDS. Prone positioning improves oxygenation and outcomes if PF ratios are very low, that is less than 150. Individualized PEEP may be superior to fixed tables in some patients only, like obese or very thin, you will have to. And then, as one of the doctors was saying, that you can use monitor esophageal pressure to guide the PEEP titration in selected cases. Next question. A 45-year-old female with severe pneumonia is on mechanical ventilation. The plateau pressure is currently 30. What is the recommended action to take? Increase tidal volume to improve oxygenation. Decrease tidal volume to reduce lung injury. increase PEEP to improve oxygenation or leave the ventilatory settings as they are?
B, I think.
Anybody with different options?
B, B.
So, can't we leave the ventilatory settings as they are?
We can leave because it's still 30. It's still 30, we can leave, I think.
So, we certainly, if we increase the PEEP, the PEEP plateau can also increase. We can decrease the tidal volume to reduce the lung injury, can we? But it is not mentioned anywhere. So the question is about the PEEP plateau basically. So if we decrease the tidal volumes, that is the only option that can decrease the PEEP plateau. So 30 is fine, but then we would like to keep it as less than 30 at all times. So 30 means if the patient coughs or bucks, there are chances that the patient PEEP plat may go high and cause the injury. So as an anticipation to that, we should try to bring it down. And the only way you can do it by decreasing the tidal volume. So we will just go into the details of that as well. But before that, a question. A 50-year-old male with history of COPD is in ICU with ARDS or acute respiratory failure with saturation of 88. So what is the target oxygen saturation in a patient of this thing?
It's 88 to 92.
90 to 94.
So we already have targets somewhere there only. So what will you use? What is the most appropriate? Will you use obstructive sleep apnea is the history of the patient? Will you use high flow nasal cannula in this patient?
I think no, B.
So
B.
the best is to use a BiPAP device in this patient. It is a non-invasive ventilation will help this patient. Okay. So NIV is the first line in respiratory failure with patients of obstructive sleep apnea because it provides both pressure and ventilatory support. Okay. A 60-year-old female with COPD exacerbation is on NIV. She becomes increasingly agitated and cannot cooperate with the therapy. What is the next best step in managing her airway?
C.
Just a second.
C. Intubate and ventilate.
Okay, yeah. Yeah, so sorry, I had to go. So what is the answer?
C. Intubate and ventilate the patient.
So the best deal here is to intubate this patient and put the patient on ventilator. So if any patient becomes agitated and cannot cooperate, the best thing that you need to do is put the patient on ventilation.
Why intubation, sir? Just agitation. Maybe she will respond with HNFC.
The problem is COPD, you don't put on HFNC. So the patient is already on NIV. On NIV, she is becoming increasingly agitated. What are the reasons for agitation in a patient of COPD with acute exacerbation?
Hypoxemia.
Maybe hypoxemia may be
So,
part of
so it is if the patient develops a fit or a seizure or something like that, then it will be a problem. These are like no ambiguous questions.
But in NIV, we have no mention, no setting, nothing setting was there. We have many other options there.
Yes. So these questions are basically to, prompt you to think. I agree that the NIV settings are not there. But basically what we are trying to discuss here is the transition from a non-invasive to a ventilatory, invasive ventilation. So one of those criteria to do that is an uncooperative patient who is COPD and who is on NIV and is, she has an exacerbation. And if you sedate this patient, let us say, if you sedate this patient and continue NIV, what are the possible outcomes? Number one outcome is
aspiration.
So we will go slow.
So number one possibility is that she will become comfortable and she will be on NIV. But what will happen is gradually she may retain carbon dioxide because the respiratory drive may go away. Second is she can aspirate because of the NIV and you have sedated the patient. And if she vomits, she will aspirate. So there are two prongs. No, one is that she can get better before she worsens. Second is that she worsens right away. Second is switching to HFNC, which is not the not the norm, which is not the guideline. It is a COPD exacerbation. So just by putting on HFNC, it is not going to help. Third is providing oxygen via nasal cannula. So we are actually coming down on the oxygen therapy. We have started the weaning off. The patient is not tolerating NIV, and with the option D is we put the patient via oxygen nasal cannula. That is also not an option. The patient is still in distress. She is becoming increasingly agitated. She is not agitated, she is increasingly agitated and cannot cooperate with the therapy. So what are the options? Do you still think that patient can be sedated and continued on NIV?
No.
So this patient has to be intubated before some catastrophe happens.
Okay.
Okay. So I have made a very nice, you can take a snapshot. This is basically when do you intubate a patient of respiratory failure. This is a one pager I have made. So what are the indications for intubating a patient in respiratory failure? Number one is hypoxic respiratory failure with PaO2 less than 60, despite non-invasive support. For example, ARDS, pneumonia, pulmonary edema, worsening situation. Second is hypercapnic respiratory failure. PaCO2 is 50 and above and pH is less than 7.25. Acidosis has entered. Now acidosis is there, intubate this patient. Third is imminent airway compromise. Suddenly patient has a seizure. Suddenly there is drop in GCS. The patient has a history of trauma or burns or whatever, contributing to the factor of airway compromise. And fourth is failure of non-invasive ventilation. You put the patient on NIV, the patient is agitated, the patient is not cooperating. This is failure of non-invasive ventilation. Now, you can give it a try of sedation, but then believe me, how many patients can we sedate and put on NIV if they are not ready to cooperate? If they are agitated because of hypoxic brain, they will need an intubation. The only matter is they will be intubated after a crash or they will be intubated when they are not crashed. So what are the steps of intubation in ICU? Number one, pre-oxygenate, either keep them on NIV or HFNO in critically ill patients, ramp up these positions, use etomidate, ketamine or propofol based on the blood pressure, scoline or just a second, I have to close the door. And then immediate post intubation ventilatory settings, preferably it is volume control or either pressure. Tidal volume to set at 6 to 8 ml per kg, not 6 ml in ARDS. PEEP to be started at 5 centimeters, titrate as per oxygenation, ARDS net PEEP FiO2 table. FiO2 start at 100, titrate as per the SpO2 or PaO2. Respiratory rate initially 16 to 22, base it on CO2. I/E ratio 1:2, adjust as per the in the obstructive diseases. Complications, barotrauma, VAP, villi, hemodynamic compromise, patient ventricle ventilator dysynchrony, tracheal injury due to cough overinflation. We will not let it happen. We will keep it between 20 to 30. How do you liberate and wean off the patient? You do a daily spontaneous breathing trials. Second is assess the patient on rapid shallow breathing index. Now this RSBI is a simple bedside index which is used to predict the success of weaning off a patient from ventilator. The formula is given here, RR by tidal volume. So if the RSBI is less than 105, it is a good predictor of weaning or extubation success. If it is more than 105, there are very high risks of weaning failure. Example, I have given it here. A patient with a respiratory rate of 25 and tidal volume of only 300 ml. So if you calculate, this comes out somewhere, the RSBI is 83. You can wean off this patient. Low RSBI means slower, deeper breathing. That means efficient respiratory mechanics. A high RSBI means the patient will become shallow when you extubate such a patient. So you measure the RSBI during a spontaneous breathing trial using a T-piece or minimal support, measured after 1 to 2 minutes of spontaneous breathing. All right. A 25-year-old male with severe traumatic brain injury is intubated and on mechanical ventilation. The current PEEP level is 10 centimeters of water and FiO2 is 40. The patient's PO2 is 95. What is the next step in managing this patient's ventilation? Anyone?
I think it's D.
G,
So,
no need to change it.
So we would just like to keep the patient there it is. So patient's
D.
PO2 is 95, PEEP is 10, FiO2 is 40. I'm not going to change anything. So patient is well oxygenated at a PO2 of 95. So eventually we would decrease the FiO2 if at all, or maybe we would start decreasing the PEEP by 1 centimeter or 2 centimeter, not by decreasing it to 5, certainly. Okay. So a 35-year-old female with acute respiratory distress syndrome is on mechanical ventilation. Tidal volume is 500. Patient's height is 170. What is the next step in managing this patient?
Decrease tidal.
So for a patient with height of 170 centimeters, the ideal body weight could be around 60. So for a 60 kg man or a female, 60 kg female, what would be the tidal volume? 360 ml. All right.
B.
So we would try reaching somewhere close to 360 ml. So I think 400 ml is fine. So the answer should be B. So for a patient of ARDS, 6 ml per kg, 170 centimeter tall, roughly 60 kgs. So that is what it is required. Okay. A 45-year-old male with severe asthma is being treated with HFNC. Now, remember, this patient came to us and we put the patient on HFNC. Now, the problem is that this patient on HFNC is breathing at 25 breaths per minute and using accessory muscles. What is the next step? Simple. Indication of NIV. Using accessory muscles.
D.
So, what we'll do? We would switch
NIV.
to NIV. So, this is one of the indications where we shift from HFNC to NIV. So we will be switching here from HFNC to NIV. If the patient with severe asthma exacerbation does not improve with HFNC and continues to show distress using accessory muscles, elevated respiratory rate, NIV should be considered. Okay, a 50-year-old female with history of DVT presents to ICU with sudden onset dyspnea, chest pain, hypoxia, D-dimer elevated. Which of the following is most appropriate next step? Chest X-ray, CT pulmonary angiogram. So we would do a CT pulmonary angiogram. Okay. So this is a one pager for pulmonary embolism. If you want to take a shot, you can take. So basically it is nothing that we have not discussed as of now. The only few things that have been added is echocardiography findings, that is RV dilatation, septal thickening. It's a D-shaped LV. So what is a D-shaped LV? Basically, when you do a short axis, you see a D-shaped. This is how you see. So the RV is dilated and LV is compressed into a D shape. So that is what happens. So D-shaped LV, and McConnell sign is right free wall hypokinesia and apical sparing that you see on the Black's view. ECG changes, S1, Q3, T3, sinus tachycardia. D-dimer is useful in low risk, not reliable in ICU, but in emergency, you should get it done. CTPA is the gold standard always. Massive PE, hypotension shock, pulseless electrical activity, submassive and low risk PE are the other types. Anticoagulation immediately, thrombolysis indicated in massive PE with shock. Consider in submassive PE. ECMO may be used and along with IVC filter only if anticoagulation is contraindicated. So pulmonary embolism is something which is very important for exam also. A 65-year-old male with COPD presents with acute dyspnea and hypoxia. pH is 7.3, PO2 is 50, PCO2 is 60. Which of the following is most appropriate next step? Easy. COPD. There is only one answer here. Put the patient on NIV. Okay. So why NIV? What is NIV? So NIV basically is a positive pressure ventilation, but without an endotracheal tube. Full face mask, helmet NIV, all of them are there. BiPAP and CPAP are there. Bi-level is where you have a IPAP and an EPAP and you have to adjust them according to. EPAP is basically PEEP in an intubated patient and IPAP is a pressure support in case of an intubated patient. CPAP means that there is no bi-level, there is no EPAP, there is no IPAP. It's just a constant, continuous positive airway pressure level, single. Indications for NIV in ICU: COPD exacerbation with hypercapnia, cardiogenic pulmonary edema, OSA patients with hypoventilation, and when you are weaning off COPD patients. Other uses are, of course, acute cardiogenic pulmonary edema, immunocompromised patients, post-extubation patients of laparotomy, and so on, and mild ARDS, early stages only, where HFNO is also approved now. Absolute contraindications are cardiac arrest, patient who is unable to protect their airway, uncooperative or agitated patient, facial trauma, relative are vomiting, excessive secretion, and hemodynamic instability. The NIV settings, mainly IPAP should be 10 to 15 and EPAP should be equal to the PEEP, so 5 centimeters. FiO2 should be done to maintain SpO2 anywhere above 88 to 92%. The difference of IPAP and EPAP is important because it controls carbon dioxide clearance. This is the important thing that you need to remember, that IPAP and EPAP difference is what maintains the CO2. There is no relation with the oxygenation. EPAP is basically PEEP, so it improves oxygenation. When you are putting the patient on NIV, monitor for any leakage, any gastric distension, skin pressure ulcers, any asynchrony. ABG should be done within 1 to 2 hours after putting the patient on NIV. Failure to improve, consider early intubation. NIV versus HFNO. Pressure support, NIV does give, HFNO does not give. CO2 clearance, NIV does give, HFNO doesn't. PEEP effect is good in NIV because of EPAP, but in HFNO, it is very low. It is just about 5 centimeters. And tolerance is excellent. That is somewhere, some point where HFNO takes the front seat, that the tolerance is excellent. It is not as good in NIV. A 30-year-old female with history of systemic sclerosis presents with progressive dyspnea and hypoxia. Her chest X-ray shows bilateral basal fibrosis. Which of the following is most likely diagnosis? It is interstitial disease or pulmonary hypertension. There are two diagnoses basically. So pulmonary hypertension is also there because that is why she is progressively dyspneic and hypoxemic. This question in itself is not a great one because ILD is there, but the patient is dyspneic and hypoxemic because of pulmonary hypertension. That is an integral component of systemic sclerosis. A 55-year-old male patient with history of smoking comes with hemoptysis, weight loss, and cough. Chest X-ray has a mass in right upper lobe. What is the most appropriate next step?
CT.
Would you not want to do a bronchoscopy? There is a mass there and patient has a history of hemoptysis also.
Yeah, bronchoscopy.
So we will do bronchoscopy in such a patient. It is the initial diagnostic procedure before subjecting them to CT. And you can take biopsy also, specifically if it is a lung mass, and that is how it will help. A 70-year-old female with a history of hypertension presents with acute onset dyspnea, cough, and fever. X-ray shows multifocal infiltrates. What is the most appropriate initial treatment?
Antibiotics.
So you will treat them for antibiotics. Pneumonia, basically you want to treat for pneumonia. A 50-year-old male with history of alcohol presents with fever, cough, pleuritic chest pain. X-ray shows loculated pleural effusion. What is the next step?
D.
Photosynthesis.
Yeah. So the answer is D.
Okay.
Thoracosynthesis. Yeah, thoracosynthesis is basically video-assisted thoracosynthesis is required here because the effusion is loculated. So, but this is just the guidelines talking. Effusion is loculated and thoracosynthesis is inconclusive. Further interventions may be considered. Of course, the next step will be thoracosynthesis, and if it is not helping, then VATS will be considered. Directly, we will not do VATS. First, we will do thoracosynthesis only. I also thought the answer is VATS, but the answer is thoracosynthesis. Only if it is inconclusive, we will go for VATS.
But I read in one book, I don't know the reference name, but
Yes.
the option was there, weights was there.
Okay. I also thought VATS should be the deal, but then it is the most appropriate next step that puts us into a dilemma, no? The most appropriate next step is that initially you try thoracoscopy, thoracosynthesis, and if it doesn't work, yes.
But it is a loculated, na? Thoracosynthesis means you need to go to the multiple area. You need to perk multiple area.
Yeah, I think
you
are also right.
By weights we can remove this one all.
So I also think that we should stick to D, VATS. Correct. Because it is already written that it is an X-ray shows a loculated pleural effusion. So why would they write loculated pleural effusion if they don't want us to mark VATS? Correct. Let's stick to VATS. Okay, this is acute interstitial pneumonia. This is revision again. A 65-year-old male COPD, dyspnea, hypoxia, hyperinflated lungs. Which of the following is most appropriate initial treatment? So the treatment is NIV only. NIV. Yeah, I don't know why this question got repeated so many times. I was probably in sleep or something. This is again repetition. So this is all I have for respiratory for EDIC, and I had a very less time, so kept on making questions and kept on. But then I think more emphasis will be there on ARDS. That is always there. From ARDS, you will get around 5 to 7 questions straight away. Pulmonary embolism, you will get around 2 to 3 questions that are like they're hard phonetics. And ABG analysis, again, there is one Winter's formula that you need to remember, although we did not discuss it here. Can anybody tell me the Winter's formula?
Yeah, it's PCO2 is equals to 1.5 times bicarbonate plus.
Wonderful. Plus
8.5, then plus or minus 2.
Yeah, 8 and plus minus 2. Yeah. So it is very important. Winter's formula, they keep on asking again and again. Any other question that you can think of?
Almost, sir, you covered everything, mashallah, but just invasive mechanical ventilator modes, if you was discussed in this, your lecture, it was more good for us. But mostly you cover non-invasive HNFC, this one.
Yeah, because these are the things now which are nowadays they are asking on repetition. And more so because of HFNC was a new thing and big thing after COVID. So I wanted to have your attention on that. So let us have this Winter's formula, some question on it. So we have a 25-year-old diabetic male and he is in decay. So pH is 7.18, bicarbs are 10 and PCO2 is 22. So according to the Winter's formula, what kind of respiratory compensation is happening here? Number one, appropriate. Number two, superimposed respiratory acidosis. Number three, superimposed respiratory alkalosis.
Thank you. And Nigeria.
And number four, no compensation.
Okay, from Nepal. Oh, excellent. Excellent. Good.
So the Winter's formula for all of you again, it is basically 1.5
I love Nepal.
into bicarbonate plus 8 plus minus 2. So this is expected PCO2. So this is how the question will come. So what do we have here is 1.5 into what is the bicarb given?
10.
10. So it is 10 plus 8 plus minus 2. This will be 15 plus 8, 23. 23 plus minus 2. So expected PCO2 range would be, let us say, 21 to 25. This should be the PCO2. So what is the PCO2? PCO2 is 22. So the answer will be appropriate compensation. Is that clear? Okay. Just for your convenience, I will give you another one. A 58-year-old male with CKD with metabolic acidosis. pH is 7.25. Bicarb is 15. CO2 is 40. So what is it? Is it appropriate? Is it superimposed respiratory acidosis? Because pH is 7.25. Is it superimposed respiratory alkalosis? Or is it a normal ABG for a CKD patient? So let's go into the Winter's formula. Expected PaCO2 is equal to 1.5 into bicarbs plus 8 plus minus 2. So what do we have? Bicarbs कितने हैं यहाँ पे? 1.5 into 15 plus 8. So 15, this will become 30.5 plus minus 2. So that means the range will be between 28.5 to 32.5. And what is the CO2 given here? It is 40. So this is superimposed respiratory acidosis. So these type of questions will come from Winter's formula. It was important, so I thought I will discuss it with you. Any other questions you may have in mind? Okay. Have a good weekend, all of you.